Hey everybody, welcome to the Athletic Potential Podcast. This is episode 11, and today we're going to talk about rotator cuff strains. We're going to talk about when to get an MRI, shoulder pain in softball players, and when is it okay for athletes to return to throw following an injury. As a brief introduction of myself, my name is Mike Matthews. I'm the host. I am the owner of Athletic Potential, where we treat a variety of different clients out of our facility, with most of our clients being baseball and softball players and overhead throwers, but we do see quite a bit of other athletes as well. And as a general recap of each episode starts off with a case. It's typically the last client that I worked with prior to recording this podcast. We then take question and answers from our listeners, and then we finish with a general recap and takeaway. So let's get right into this episode. So I just recently finished treating a right-hand baseball player, 22-year-old, who has posterior shoulder pain that started when he started to throw more following his season this year. He's currently playing in a summer league, and he was unable to throw, or I guess he had pain after his last outing as a pitcher. And he came to me complaining of sharp pain on the posterior aspect of his shoulder. It was the first time he's really had it. No incident, no trauma, just following pitching, he had this increase in pain. He said that the pain had been around for about a week, and then he tried to throw on it, or throw again just a few days prior, and his pain returned, and he was unable to get back on the mound and pitch. I then saw him a few days later and just saw him for his second visit just recently. So in his case, we did a bunch of testing on his shoulder, all of which, we look at posterior shoulder pain in baseball players, and there's a lot of different things that could be causing that type of pain. And in his case, he tested negative for all of what we call the passive restraints. That's your labrum, that's the capsule. And when we tested his rotator cuff specifically, he tested positive, meaning he had pain with resisted testing to two different muscles in his rotator cuff, one called the infraspinatus, the other called the teres minor. And these muscles are more activated in the pitch, specifically in the follow-through phases of the pitch, and with the whole job of trying to slow the arm and slow the shoulder down once the ball has been released. And that is the exact time when he is having his pain, and it is sharp. And so we started treatment with some basic range of motion. He actually tested very poorly with his external rotation and internal rotation. For those that have listened to previous episodes, we talk about total arc of rotation in his shoulder. That's basically how much range of motion back and forward added together he has, and it needs to be a certain amount of range of motion compared to his non-throwing side. And he had a lack of about 20 to 30 degrees that was really problematic. And we noticed that he also not only had a significant lack of range of motion in his rotation, but he also had a significant lack in his flexion, his ability to take his arm directly up overhead. However, this was less compared to the other side, less of a difference compared to the other side. He had a lack of total shoulder range of motion side to side, which it basically shows that he's not a really loose jointed guy. He's a little bit more stiff jointed, which there's nothing wrong with that. It just needs something we take in consideration. So following working on some range of motion, I did some shoulder mobilizations in all directions, specifically more posterior and inferior, all of which were pain-free. We then did another version of kind of a muscle energy technique, followed by a positional release technique to try and improve his range of motion, which we were able to do by about 20 degrees, which was really good. And following that, following his range of motion and mobilizations, I did some rhythmic stabilizations, basically just exercises to turn the muscles back on surrounding the shoulder to improve the ability of the shoulder to keep the ball in the middle of the socket, and that was not painful as well. And then we finished treatment with dry needling specifically to the tendon and muscles of the infraspinatus and teres minor. And we haven't had him return to throw yet. Like I said, I just treated him recently. He had no pain and full range of motion today upon his last visit. And I told him basically, look, if you have no pain at this point, we need to go ahead and test and see if you have pain with throwing. So I told him it was okay to go ahead and throw today after his appointment, and then basically call or text me and let me know how it went to determine where we're at in trying to get him back on the mound as soon as we possibly can. Now, typically, in his case, I was a little worried that we might have to actually shut him down, and since he's kind of in a specific schedule in that he's out of town coming into town to play in a summer league, I really want to try to get back on the mound, and if it doesn't work out, then we may have to make some decisions about him going home. He's from Colorado, I believe, and so we want to make sure he goes home and gets it healed up right if this doesn't work. But since he's here on a specific assignment to play baseball and develop in the summer, we're going to go ahead and let him try throwing. So, and I know that there's a question later in this episode about when is it okay to return to throw, and we follow the same principles with him that I'll share later in this episode. So hopefully he texts me back later and tells me that things actually went really well. I told him he's only to throw about 60 to 90 feet, nothing with significant intensity, to basically just drive the car around the block and let me know how it goes. And so hopefully we'll see some improvements from him. Hopefully we'll get him back pitching here by next week, and then we'll go from there. So that's our case for today. I'm really interested to see how well he does. He had such a lack of range of motion in his rotation in his shoulder that I think he might have just had a loss of rotation throughout the course of a season that now has basically caused some problems in the backside of his shoulder because he just doesn't have enough rotation to be able to control the pitching motion anymore. So hopefully just improving his range of motion and the health of the tissue of those two muscles that were mentioned, using dry needling and a few other methods, I think hopefully we'll be able to see him back on the mound fairly quickly and back performing. So, all right, that's the case for today. Let's jump right into our questions. As a reminder, if you do have questions for the podcast, please go to the website www.athletic-potential.com/podcast. There's a button that you'll just need to click. It'll say ask a question. It'll ask for some specific information. Go ahead and input your question there. As a reminder, if you want a more specific answer, please input your email. If not, you do not need to put your email in to ask a question. However, I may not be able to answer more specifically to those things that you need if your question requires that. So please head to the website, ask those questions so we can answer as many as we can. We'll answer all questions that we get. Just so far as we've batched our questions, we keep seeming to get 2 or 3 questions total. I think we've had maybe one episode with 4 questions. But like I said, ask your questions. We're happy to answer them. We'll get to any and all that we get. So let's go ahead and get started. Our first question is from Kevin. He says, I recently took my son to a doctor for elbow pain. That's a bummer. I asked the doctor if we should get an MRI, and he replied no, as it was not warranted. When do you like to have your clients get an MRI if they have pain in the elbow? Now, I'm assuming your son, Kevin, is a baseball player. Other than maybe had trauma, there's a lot of kind of big question marks about maybe what's going on with him. If he has the doctor's saying it's not warranted. I doubt it's traumatic, but let's assume he's a baseball player. And I don't know how old your son is either. It makes a big difference if he's 12 versus if he's 16, 17, 18, or in college. And so, and then one other assumption I'll make on this, just to help kind of to answer this question, is let's assume this question's being asked in the time of midsummer, because it's kind of where we're at now. And so we're midsummer. You go to a doctor says don't need an MRI. He's a baseball player. We'll see him as a pitcher. And when do I like my clients to get MRI, baseball pitchers wise? So here's how and I may have to kind of go around about here before I get to my direct answer, so bear with me. But if I have a client who's a baseball player and he comes in with inside elbow pain, medial elbow pain right here, and it's from throwing, and let's say he's a teenager, 16, 17, 18, and my first assumption, and this is the way I was trained, is that we assume that his elbow pain is coming from the ulnar collateral ligament or the Tommy John ligament first. As the incidence of injury in baseball players, specifically pitchers in that age group now, is so high, it's kind of hard not to assume it's that ligament first. Now, the other reason we want to assume it's that ligament first is if you look at the other structures that are on the inside of the elbow, that's your ulnar nerve, that's your flexor pronator mass. It's a group of muscles that all attach to the bone in that region. You have your UCL, which we already mentioned. If you look at what potential injuries there could be to those other structures, we didn't mention bone, so some epicondyle problems, avulsion fractures, growth plate injuries, those type of things. If we just take into consideration what injuries and treatments will then take the longest to return from, that helps me at least decide when to have patients and clients get MRIs. So here's the way I look at it. And I'll use a recent case maybe as an example to help. We had a pitcher come in. He was a little bit older. He's in college. Maybe your son's in college, Kevin, but he was in college. He was having medial elbow pain. And I assumed it was the UCL, hoping that it was the ulnar nerve. He had definitely had signs of both. And so I assumed it was his UCL, and I said, okay, all right, let's think about this. If we get an MRI and it shows on the MRI that the UCL is torn and needs surgery, specifically Tommy John or UCL reconstruction, we know that the turnaround time and recovery time for Tommy John surgery is around 12 to 15 months. So at this point, I then look into the future and say, okay, if you had the surgery today, mid-summer, we'll say July, 12 months from now, you're back throwing. So in July of next year, you're back throwing. And basically what that means to me is that you lose your season in the spring next year if you have to have Tommy John surgery. Now, in that case, it doesn't necessarily make sense that we need to go get MRI right away, because if it ends up being the UCL and needing Tommy John surgery, you're out of season either way. And so there's no reason why we can't maybe try and try and rehab and get back to activities and back to throwing now. Now, here's the thing though, is that we don't know if it needs reconstruction. It may need a repair. The ligament may need a repair. Now, repair time, turnaround times anywhere from 6 to 8 months. And if we use 6 months or even 8 months from mid-July or July, we're now in January and February, and we are starting spring season. And that means that that player is now back for their next season. They don't miss a season. However, if we wait until August or September, now we're cutting into spring season. And if we're more conservative and don't get an MRI, and we don't find out that this ligament needs a repair, then we may compromise the season if we don't get an MRI sooner. And so that would be one of those things where I tell everybody, look ahead and assume a couple things. Assume you need Tommy John surgery, which is 12 months. Where are you going to be at? Does it really matter if we get an MRI right now? Look 6 to 8 months ahead and determine if you need an MRI, or determine if it's going to affect your season or not. And if it does or doesn't, then you can decide to get an MRI. If it's July, I'm getting an MRI sooner than later for most of my clients, because I need to rule out a problem with that ligament that's not going to need surgery, specifically a repair. Because if it needs a repair, we can most likely get that client in to a surgeon and get the repair done and still save their next spring season. Now, that's if they need a UCL repair. If they need Tommy John, they're out for a year. And at that point, it's one of those maybe, we're pretty much, you just go ahead and get it done and give yourself a little extra time to rehab. Now, if it's an ulnar nerve problem and say it needs surgery, that's an ulnar nerve transposition where they take the nerve from here underneath the bone and put it up here in front of the bone so it doesn't get tension when you're throwing. That's anywhere from 6 to 8 to 12 weeks, depending on how the surgery goes, return to throwing, pitching, and competition. So realistically, that's not going to affect anything in mid-July, and that can be done fairly quickly, and we can rehab quickly back. If it is a little leaguer's problem, now we're talking anywhere from 8 to 12 weeks, depending on how bad it is, to get somebody back. That's 3 months. So if we get an MRI, it still helps us to understand if it's the growth plate. And a lot of times we can see that on an X-ray. So if I'm suspicious of a growth plate injury, I typically will want somebody to go get an X-ray first, because we'll be able to see distances in the growth plate and be able to diagnose a little bit better from there. Or at least the doctors will be able to. Now, say it's a bony problem, a fracture, or maybe something like that. Almost always go get X-rays first. But the idea is, and coming back to your question, and you more asked specifically, when would I recommend my clients get an MRI? Well, I think it all depends on timing. It really does. I know there's a cost associated with it, and I don't want to downplay cost, but when it comes to not only making sure that we use our time most appropriately and give everybody a chance to get back to season and maybe not miss a season, I think that's really important. But not only that, but if I get an MRI on a player and the player has a negative MRI for a problem with their ligament, I now know, as a clinician, hey, I can go after this. We can get that. We know it's either muscle, nerve, or maybe some correlation to bone, or maybe the ligament's irritable, but we can at least address it. We know it's functionally and its integrity is good, and we can kind of advance and move forward with confidence. And it also is a nice peace of mind for the client to know that their ligament is healthy based on an MRI. Now, I know there's people out there going, well, MRIs aren't fully conclusive. It could have been damaged. They may find more if you got more imaging, but I can tell you that if I have a client who has a fairly benign MRI, I'm going to go ahead and advance, and we're going to start going in regards to the rehab process as if the ligament is okay. And I can tell you that if we go through the rehab process and we're not seeing the responses that we expect to see, we're still not out a significant time period. Usually, if I'm not seeing significant improvements with anywhere from 3 to 4 weeks, I'm starting to wonder if the MRI really showed us what we wanted to see. And at that point, we may go get additional imaging and have them go see. At that point, I usually send them to a surgeon who's very adept at looking at UCLs under ultrasound and or looking at the MRI, or maybe getting an arthrogram to really rule out that the UCL is the problem. And by the way, if they're not doing better in 3 to 4 weeks, I'm usually referring them to a doctor at that point, usually the same surgeon or someone who's baseball specific, to really figure out what we need to do to get this thing feeling better. Because if they're not responding from rehab in 3 to 4 weeks, there's not likely a chance that they will respond without some additional measures. So, Kevin, I hope that answers your question. Again, I think the best way to maybe do this would be, take whatever date it is. Look 12 months into the future. That's pretty easy, right? I mean, if you're February right now, say it's February, March, and someone goes out and the pitcher goes out and throws, and bam, they know their ligament blows, and it's not good. They go to the doctor says you need Tommy John. They're having it right away because in 12 months their season is just starting again, and so they want to get that going as soon as they can. In 6 months, they've got plenty of time if it's in February or March, right? And so if you're looking at repair. So I think best way to look at it is if you're concerned about your son not having an image and the doctor's maybe not ordering it because they don't feel like it's warranted, the best way I look at it and the way I counsel my clients is to look into the future, 12 months and 6 months, and decide if you had to have a surgery, hopefully you don't, but if you did have to have a surgery, how much would the next season be affected? And that'll help you determine whether or not an MRI is warranted more immediately or whether you can wait and try and rehab and then go from there. So I hope that helps. It's a bit of a long-winded answer. I'm not sure I gave you a great clarity on that, but it's definitely something that I constantly am talking with clients and patients about, is about imaging. I'm lucky in the state that I am. I'm able to order imaging and to get the imaging as needed. And so a lot of times I'll just order the imaging for the client and then read it, and then have that surgeon read it and have a radiologist read it too. So we all feel really confident in what's going on. And so, Kevin, I hope that helps. If you do have questions, you can always reach out. We're happy to talk about this over the phone. Email works too. We're happy to help in any way to help answer these questions. These are kind of tough questions, especially if your son maybe 17, not a lot of college interest, and maybe going into a senior year. These can be a tough question for his career. So Kevin, hope that answers, and reach out if it doesn't, and we'll try and help you out. All right, our next question comes from Ashley. Ashley says, if a softball pitcher has pain in the front of the shoulder, what is your first thought as to what the injury is? I don't think I have a podcast long enough to tell you how many things I think it is on a softball pitcher's anterior shoulder, like front shoulder. There's a lot of stuff there, and oh my gosh, so specific. But let's finish your question, and maybe we can find get to the bottom of this. So I know that you can't give specific medical advice, but it seems that I'm seeing more pitchers with pain in the front of the shoulder than anywhere else. Okay. So Ashley, I think the best way to answer your question is this. Unlike the previous question from Kevin, where we have elbow pain, medial side elbow pain, that's like, okay, we're going to assume UCL in pitchers, baseball pitchers that is, until proven otherwise. In softball pitchers in the front of the shoulder, so pain in here, anywhere in here, that's the thing, it's a really general area. There is a lot that can go on here. And I can tell you that if I have a softball pitcher that comes in complaining of anterior shoulder pain, I already know that the evaluation's an hour. Even if I don't even look at elbow and the rest of the body and the way she moves, I am at least an hour getting really, really good history, and really trying to understand when the pain started, how much they've been pitching, how long have they been pitching, what are the mechanics. I'm looking at videos. We're trying to really get to the root of it, because, I mean, you asked the question, what's your first thought? Oh my God, I mean, I went biceps tendon, pec major, pec minor, anterior capsule, coracobrachialis, bone problem, depending on the age of the athlete. And I mean, those are the ones that just rattle off my head. And then now that I'm looking at it, we're thinking nerve injury, brachial plexus injury, thoracic outlet syndrome. I mean, there's a lot here. And so, Ashley, I think the best way to answer this question is when we look at anterior shoulder pain in pitchers, in softball pitchers. I always seem to ask this question. This is probably to help you, and that is, at what part of the windmill delivery is your pain, right? And so we can separate it out. And in the research, it talks about different o'clocks, right? From 12 o'clock to 3 o'clock, or 9 o'clock to ball release. And there's more than that. But the idea is, I'm really trying to understand where the pain starts and what phase, because that'll tell me, based on the research that we know, what muscles are activated during that, more activated during those phases, what structures are under more stress based on body position and shoulder position. And from there, we'll be able to kind of at least go from that big list of things that I just said to a smaller list, and then be able to test more specifically. And so I can tell you this, there's probably one phase of the throwing motion, and now that I think about it, I have about three counter arguments from what I'm about to say. But I can tell you from 9 o'clock, which is the arm directly behind the body, to the point of ball release at the side, we know that there is a significant amount of biceps brachii, long head of the biceps tendon stress. And not only that, but we're seeing significant amount of anterior capsule stress, the part of the shoulder in the front that holds the shoulder together. There's ligaments as a part of that capsule, and we know that they're getting a lot of stress during that phase. If I have a softball pitcher come in and they say it hurts from when I'm back here to the point I release the ball, I can tell you right now, I'm testing anterior capsule, I'm testing the long head of the biceps brachii, and I'm testing for nerve problems, because we know there's a significant amount of traction, the arm's trying to pull down really, really quite far during that phase. And so, Ashley, I know this is a really loaded question, and if you are seeing more pain on the anterior side, or more players, I don't know if you're a coach or if you're just a parent or what, but the idea is if you feel like you're seeing more of this type of pain in the pitchers that you're a part of, whether that's on a team, whether that's on multiple teams, the idea is we need to start looking at one, mechanics of the pitch, and two, strength conditioning programs for those athletes. And if there's a part of a team or a specific group of pitchers that are always together, always training together and doing different things, it may be the way they're training, it may be the lack of training, but there's certain things that can be definitely be done to improve and to decrease the stress over the front side of that shoulder. And so, yeah, if I see anterior shoulder pain in a softball pitcher, I think there's a lot of stuff going on there. I think the other thing I would always ask is, how much have you been pitching lately? We know that there's obviously there's no limitation on pitch counts in regards to softball players. Not that I'm arguing that there should be. I think there should be maybe it should be monitored a little bit. I'm not sure about regulations yet, but we do see quite a bit of shoulder injuries in softball pitchers. And I know in the baseball world, when they started seeing that, they started regulating it with pitch counts and those type of things. But that's another podcast in itself. But the idea is, I would look at how much they're pitching. I'd look at how fast, or basically how the volume of pitching, did it increase dramatically? Did they come from an off season or a semi-off season and we're only pitching a little bit, maybe 30 to 50 to maybe even 70 pitches a game? Now they're pitching in weekend tournaments, pitching 3 to 4 games in a row, and maybe that happened from one weekend to another. That's just an overuse, overstress. There's just no real good way to that player needed to be ramped up longer. And so maybe that's the answer to that. But I look at volume of throwing. There's just a lot of variables here. And if you have somebody specific, Ashley, this is a great conversation. You just reach out to me. Let's see if we can't maybe jump on a phone call. I don't know where you're located. If you're located near us, we're located in Utah. But if you're not located here, we definitely have virtual options that we like to use. And so I want to make sure we answer your question. And I want to make sure that there's something specific, because you said, you don't give specific medical advice. I'm happy to answer specifics if you have them. But I think it is a general takeaway for those people listening. If you're seeing a significant amount of anterior shoulder pain in your pitcher, or you are the athlete and you're feeling it, I can tell you this: they don't typically get better. They typically get worse with more throwing. And I'm not saying you have to stop throwing. I'm saying that things need to be done to improve the throwing motion, to decrease the stress over the front side of the shoulder. So this is a really good question, Ashley. There's a lot of cool research out there that they've looked at with softball players. And I can tell you that's a pretty underserved population, and we see quite a few. And a lot of those players never actually come to us unless we find them. I happen to run into a softball player that during a state tournament, and I could tell that maybe she was having some pain, and talked to the parents. And the parents were like, well, yeah, we just kind of assume we'll let it rest and then it'll go away. And I said, no, you need to address this, because it's only going to get worse, because she's pretty good. And so she's going to end up pitching quite a bit more. So the idea is, if we're seeing pain, let's get it addressed. The other thing is, there's a lot of things that could be wrong here, and we need to make sure that we look at all the facets to identify it correctly. I don't think it's appropriate to just say, hey, anterior shoulder pain is biceps tendon. I think that's everybody's favorite answer in the softball world. Absolutely not. I mean, it is a common tendon that is injured in softball pitchers, but it is definitely not the only thing. And typically it gets overused and overworked, not because it's the problem, but because it's trying to do the work that something else in the body or the arm is not doing. And so it doesn't fix it by just trying to fix the tendon. You got to fix the rest of the throwing motion and make them more efficient. So Ashley, great question. Reach out if you have more specifics. Happy to answer it. All right, final question for today. Question 3 comes from Dave. You have mentioned previously about when you get your post-op clients returning to throwing, but I was wondering, how do you know when to get your non-post-op clients returning to throwing? Do they go through the same process? For those that don't know our process in regards to returning to throw programs, our post-op clients have to go through a fairly significant process to get back to the return to throw phase. That typically includes a full strength conditioning program that takes quite a while, a power development program, a plyometric development program, a shoulder endurance strength and isometric program, as well as then passing what we call a return to throw assessment. If they pass all of those things, then we start them on an interval throwing program, and then they start progressing back towards returning to competition. So yeah, that's a lot of stuff right there. Now, do we do the same things for those that maybe come in and just have like a shoulder strain? As we mentioned earlier in the case, we have a patient that came in with an infraspinatus teres minor strain. He really never stopped throwing, except for when I first saw him. I told him he just not throw for the next 3 days. So if I stopped him from throwing, it's been 3 days since I stopped him from throwing, and I'm now having him throw the day after I treated him, which is today. So he's throwing, what would that be, 5 days? He's going to go out and try throwing in 5 days. The way to answer this question, Dave, is it absolutely depends on the amount of time off that they've had from throwing. If someone's had a very short amount of time off from throwing, then I feel a little bit more confident. Sorry, let me rephrase. If someone's had a significantly long period of time off, a shutdown period, typically greater than about 3 weeks, then we're really having them come back and show us on that return to throw testing and going through a plyometric program as well before we consider getting them back into throwing. If they've only had a week, maybe 2 weeks off, and we've been trying to maintain power, maintain the arm motion, and I don't think I have any reservations maybe having them coming back and throwing sooner, or basically I have the mindset that they never really stop throwing. We're just going to start on a very gradual process, but the gradual process ramps up quickly. So the best way to answer your question, Dave, maybe would be with a case. So with a case, we had a client come in, shoulder pain, could not throw, couldn't even get the throwing motion. So I guess that's another answer to this question is they have to be able to show me appropriate throwing range of motion in the shoulder and in the elbow without pain on the table and in standing. Then they also have to show me adequate strength compared to the other side. Those are the things that we can test the same day. And if they test normal on those things and they have no pain, then at that point, I then look at how long they've been off from throwing. If they've only been off from throwing for less than a week or 2 weeks, I typically am okay not having to go through the return to throw criteria at that point and trying to then progressively work towards returning to throw on a kind of a week to 2 week basis. And so I don't know if that answers your question, but the idea is the longer the shutdown period, the more likely I'm having them go through the entire return to throw process. And so I hope that answers your question. And just know that there's a lot of facets that it comes to return to throw programming at that point. And I try to simplify it. Sorry, I kind of rambled a little bit there. I think the best way to look at this would be, let's take into consideration a few things. They have to show good range of motion, meaning normal range of motion without pain. They have to show good strength testing without pain. And then you need to take into consideration how long they have not been throwing. If it's greater than 3 weeks, then I would consider having them do a return to throw test and to demonstrate that their shoulder, elbow, and everything, all the other parts are ready for the throwing motion and the stress that comes along with it. If it's less than 3 weeks, then I would consider maybe not having going through the return to throw and rather just kind of getting back into throwing. And when I say back into throwing, I really should preface this. I mean, we're talking throwing 60 to 90 feet with a baseball. And a lot of times I won't even have them throw a baseball. I'll have them start throwing a football for various other reasons of just trying to even get the throwing motion. And there's a little bit of a... I give a baseball to a baseball player and they want to throw it hard. That's good. If I give a football to a baseball player, they kind of have to figure out how to throw it because they're so used to a baseball that it doesn't allow them to really throw it hard. And so a lot of times I'll give them a football to start, and then we'll work into a baseball. But the idea is to get them throwing back as soon as we can without pain, so long as they test good with range of motion with strength. And it hasn't been a significant amount of time. And I don't know why I'm keying in on 3 weeks. I think it really depends on the player. But it always seems like anywhere from 2 to 3 weeks for me, if they have not been throwing for 2 to 3 weeks, I'm starting to get iffy on whether or not we need to do more testing to make sure that they're ready. If it's been more than 3 weeks, it's an automatic. They need testing. They need to really show me that they're ready to throw a baseball. And anything less, I typically am actually having them going through the throwing motion that's not painful, knowing that I'm trying to get them back quickly. And we kind of talked about that case earlier with the rotator cuff strain earlier. I mean, he'd only been off for 5 days. I have no problem letting that guy pick up a baseball and throw it at practice without supervision because he hasn't been off of throwing for very long. And he's demonstrated everything else I need him to demonstrate. So his body really hasn't deconditioned from throwing at all. It's still ready. It's still conditioned. It's still there. The question is whether or not he can actually tolerate throwing. So, Dave, I hope that answers your question. It's a great question because I can tell you right now, and you've heard me say it on the podcast if you listen, every part of our throwing progressions is individualized. Every part. I have 3 guys in here on return to throw programs today. One who had shoulder surgery, one had a lat repair, and the other one had a UCL repair. And they're pretty close to the same time period. I'd say just a few weeks off of each other. And their throwing programs, they're similar, but absolutely not the same. The guy with the lat repair, we've got him doing more of a high intensity day that I don't even do with my UCL clients, because I feel like in his case, his lat is adapting better to a little bit higher stresses than to trying to go lower stresses, and he's been out for longer. And so every throwing program we do, every return to throw program, or every client that's returning to throw, we always assess individually and then actually write an individualized throwing program specifically for them. So I hope that answers your question. Those are some key variables that we look at with each one of our clients, and then we just take into consideration the athlete, how conditioned they are they ready? I mean, I've definitely held athletes back that have not stopped throwing, and I've told them, look, we need to stop throwing for a little bit, or we need to go so light on throwing because there's so many other variables in your athleticism, meaning you don't have adequate strength throughout your entire body. The kinetic chain, their ability to biomechanically link everything together to have an efficient throwing motion isn't there. And so a lot of times I'll tell them, like, look, we need to fix these other things before we get you back to throwing, unless they're trying to get back to competition quickly. Like in our case earlier, he's trying to pitch tomorrow if he can. And the idea would be all of those things we need to take into consideration about getting people back to throwing. Sometimes baseball players just need to pump the brakes, give it a few minutes, give it a few weeks, give it a month, sometimes a month and a half, and just really focus on the things they're not good at, the things that are suboptimal, and all these kind of little naggy issues with shoulders and elbows and other things that they may have, they may just go away because we've just improved everything else. And it may not be the tissues that are the problem. It's just, or that they need rest or anything. They just need more time and better mechanical efficiency and more strength and those type of things in the rest of their body. So, Dave, I really appreciate your question. It's a great question because it definitely makes me reflect a little bit on how we manage these guys. And they do the same thing for softball players as well, softball pitchers. It's the same thing. We really kind of look at those type of things, those variables mentioned, and then really decide based on an individualized basis how and when we should get those players back to playing. So, and then obviously trying to get back to competition and the players' goals also makes a big difference. So I hope that helps. Yeah, that's all the questions we have for today. As a general recap, again, I think I say individualized. Every episode, everything needs to be individualized. It just goes a lot better. Everything seems to do a little bit better. But I think we've really kind of replied or really touched on that today. You know, when to get an MRI. It highly dependent on, you know, where you're at in your season and where you're at in your career and those type of things. In regards to softball players, there's definitely no one thing in regards to shoulder pain, it doesn't seem like. And so we got to really look at each one of those players individually. And then obviously when we talk about returning to throwing, that's an individualized basis. So great questions. I appreciate everybody that's submitting questions and asking questions. And I encourage everybody to ask their questions so we can get them answered. We want to answer as many as we can. We want to help as many people as we can. Also, please rate, review, and share with your friends that we're here. We definitely want to help out as much as we possibly can. I appreciate you taking the time to listen, and we'll catch you next time. Thanks.